So friends, welcome back. We talk about the lecture number 5. Regarding the recent updates in medicine and the recent update from Harrison 19th edition. So in the previous lecture we talked about the coronary artery disease and we have done the reperfusion of myocardium. But now we talk about one more recent advances. Now this point is not given in even in 19th edition of Harrison. So we talk about something called black hole phenomena. Black hole phenomena. Black hole phenomena. What is this? This is recent, not given in even 19th edition also. So we are going beyond 19th. Here is the coronary artery. And here is the plaque, which we have tried to open them or by stent, but at times we are not get success. So what they do, once they have done the angioplasty, later on what they do, they irradiate this part by brachytherapy. They do brachytherapy. They do brachytherapy. That means they will destroy they completely irradiate that part of endothelium, so that there is no chance of regrowth of this particular plaque. So this phenomena is known as black hole phenomena. This is the point number 1. The black hole phenomena is done in case of coronary artery disease. One more thing is slow flow phenomena. Slow flow phenomena. Slow flow phenomena. What is this? Just in the previous lecture I told you the best way to diagnose angina is by history. History, when he says, when I walk I have pain chest, when I stop the pain disappear. And why it happened was, here is the coronary artery, here the myocardium, here the plaque, blood supply, heart rate 70, normal. But when patient walks, heart rate increases, oxygen demand increases, supply cannot increase because of fixed obstruction is there. So what we call as exertional pain chest, and that you can pick up by ECG, TMT or by angiography. At times patient come with history, but you investigate, his ECG is normal, his ECG is normal, his TMT is normal, his coronary angiography is normal. CAG stands for coronary angiography is normal. But that means we cannot prove that he has some problem. But he gives the history of exertional pain chest. Now the new thing has come up. Why? So he has, in slow flow phenomena, he has number 1, exertional pain chest. Exertional pain chest. Number 2, exertional pain chest. All investigation normal. All investigation means ECG, TMT, angiography is normal. But why he's having? Because of arteriolar spasm. Arteriolar spasm. The coronary arteriole, they remain in spasm or they do not relax. So there is tissue. Problem lies in the arteriolar level, not in the main coronary artery. And that is so-called slow flow phenomena. And treatment of this is diltiazem. We give diltiazem in this patient. Because diltiazem is a very good dilator. So friends, we talked about the slow flow phenomena, in which we talked about the exertional pain, chest, all investigation normal, arterial spasm and diltiazem is a treatment. This is the box number 2, slow flow phenomena. Slow flow phenomena. Now, this is the coronary artery. This is the plaque, which is calcified. Calcified. In calcified plaque, we can never do angioplasty. Patient has come for the first time. We have sent him for angioplasty, but in the angioplasty, they found the plaque is calcified. They say angioplasty can't be done, so they send back the patient for angiography, so for bypass surgery. Now they do, and they waste precious time during this. So what they do, before sending this patient for angioplasty, they do CT scan, what they call as electron beam CT scan, to look for the calcified plaque. Calcified plaque. Electron beam CT scan is done to look for the calcified plaque, and now they do even quantification of plaque. We use Agatston's score to quantify the plaque. Quantify the plaque. This is the box number 3. Electron beam CT scan, and to look for the quantification we use Agatston's score. Now a new technique has come up, so-called transmyocardial. Myocardial reperfusion therapy. Reperfusion therapy. Let's learn the subject. What is this? Here is the myocardium, and here is the coronary artery, and this is totally blocked, fibrous, totally blocked, fibrous. So we can't do angioplasty, we can't do bypass surgery. Now what they do? They enter the LV cavity. This is the LV cavity. They come to left ventricle and they do multiple holes by laser. They make multiple holes by laser. So now blood can diffuse directly into the via this hole, and this is known as transmyocardial laser reperfusion therapy. Laser reperfusion therapy. Transmyocardial laser reperfusion therapy. Now we talk about new drugs in the treatment of CAD and arrhythmias. New drugs. We have ranolazine. Ranolazine for angina. We got trimetazidine to be used in coronary artery disease because it stabilizes cardiac metabolism. Then the drugs for arrhythmias, we got Varnakelent, and Donidalorsen. These two drugs are for atrial fibrillation, and that is box number 5. New drugs in CAD, Ranolazine, Trimetazidine, Varnakelent, and Donidalorsen are the new drugs we talk about for CHF. Okay. Well, one more thing that I like to add, in case of coronary artery disease, single most important poor prognostic factor is presence or absence of CHF. For that we use Phillips classification. Phillips classification. Phillips classification. Phillips classification we use to know the prognosis in a case of MI, and it is based on presence or absence of pump failure. Pump failure means CHF. So we use Phillips classification to assess the prognosis of a case of MI. This is what we call as, and based on pump failure. This is the box number 6. This is the box number 6. So I hope you got plenty of new information regarding cardiology in this lecture, and of course a part was done in the previous lecture also. So now we move something. What are the new? So we do something for the neurology. Neurology. New updates in neurology. So new update in neurology are, first of all, we talk about multiple sclerosis. In multiple sclerosis, what are the prophylactic drugs we are using? We have prophylactic drugs. We have glatiramer. Mitozantron. Natalizumab. Alemtuzumab. Interferon beta. Fingolimod. Cladribine. Make a box. Number 1. These are the drugs which were given in 18th edition also. Out of all these, you may or may not remember anything, but should not forget interferon beta. Why not? Because this is the most effective drug in the prophylaxis for MS in today's time, and that's why this is the most widely used drug for the prophylaxis of MS. And number 2, this is the only condition where we are using interferon beta. Remember, interferon alpha and gamma we are using at many places, but as of now today we are using only in multiple sclerosis. But there are few drugs which have come in 19th edition extra. The new drug for prophylaxis which are there in 19th edition has an dimethyl fumarate. Dimethyl fumarate. Dimethyl fumarate is a drug that we are using for prophylaxis. Second is teriflunomide. These two drugs are prophylactic drugs which have come in 19th edition of Harrison. The previous one were there in 18th. These are the two new updates. Dimethyl fumarate and teriflunomide are the two drugs that we are using in this condition. Okay. Next point. Well, now something about the anti-epileptic drugs. So before I discuss the changes which have come, so I'll first tell you what was there in 17th edition, then what came in 18th edition, and what came in 19th edition. And of course, our purpose is to know what changes have come. Right, sir? So, in 17th edition of Harrison, treatment of epilepsy. First line treatment, second line treatment, grand mal epilepsy, focal seizure, absence seizure, atypical absence, and myoclonus. Grand mal epilepsy, focal seizures, absence seizure, atypical absence, and myoclonus. So in 19th edition, valproate, many drugs, valproic acid, valproic, This was in 17th edition. So that time only the question came. Drug of choice or absence seizure was the question came valproic. And now what changes happened in 18th? In 18th edition, what he did, this is, now it has come to this place. 18th. In 18th, he shifted valproic from this to this. Now, what is there in 19th? Valproate remain like this, but a new drug, lamotrigine. I'm writing L. So, first line treatment, L, and L. Now, as per 19th edition, lamotrigine has taken over valproate because this is first line treatment in all types of epilepsy. So friends, my purpose of guiding is now you got two drugs, valproate and lamotrigine, which are equally effective. So when the question comes, you use your judgment. And I'm quite sure examiner will never put these two drugs together because examiner knows both are equally effective. So you will get one, either valproate or lamotrigine. Valproate has been there for the last so many years in the 2 edition. Lamotrigine is a new drug, upcoming drug. So if the question answer is lamotrigine, go for lamotrigine as the best answer for drug of choice as epilepsy. Okay? So now you can add upon the drug having widest range of action should be lamotrigine also. Epilepsy, lamotrigine. lamotrigine. Box number 3. Now the new drugs which have come are new drugs for epilepsy are new drugs for epilepsy. Stiripentol, and rufinamide. Rufinamide we use for Lennox-Gastaut syndrome. We use for Lennox-Gastaut syndrome. In fact, this question came in last year at AIMS exam. That rufinamide is the drug of choice for Lennox-Gastaut syndrome. The new two drugs are stiripentol and rufinamide is the box number 4. Okay. Now, new drugs for treatment of Alzheimer's disease. So, Alzheimer's disease, we are using new drugs is for Alzheimer's disease. The drug of choice is for Alzheimer. Drug of choice is donepezil. The other drugs which have come are rivastigmine. Other drugs, rivastigmine, galantamine, and huperzine A. This drug is not given in 19th edition also. It's a new drug. It's not given in 19th edition. All these drugs are anticholinesterase drugs. All these drugs are anticholinesterase drugs. But we got one more new drug, memantine. Memantine is a new drug. So, memantine. This drug is a NMDA receptor antagonist. This drug is a NMDA receptor antagonist. This is the box number 5. This is the box number 5. So drug of choice is donepezil. Others are rivastigmine, galantamine, huperzine A, memantine. Other drugs. Box number 5. But new thing has come up that we can even prevent or delay Alzheimer's disease. We can prevent or delay Alzheimer's disease. Now there are certain drugs have been approved. But before I say something, if you read 17th edition, they mention about some preventive drug. In 18th, the list changed. In 19th, they further changed. So now I give the latest thing which have been retained or have come up in the 19th edition, things to prevent Alzheimer's disease. So, for prevention of Alzheimer's disease, prevention or delay of prevention of Alzheimer's disease, we can use hormone replacement therapy. And number 2, if you reduce homocysteine level, homocysteine level should be reduced. Highly and widely discussed in all the conferences. Till now, you are knowing that homocysteine is to induce CAD, but now higher the level of homocysteine, more are chance of Alzheimer's disease. And one more thing, uncontrolled diabetes is a very, very important, strong manifestation for Alzheimer's disease. So they say if you don't control diabetes in a patient, that can induce Alzheimer's disease, or other way around, Alzheimer's disease is more likely to occur in uncontrolled diabetes. Okay? This is the latest 19th edition base, but again telling you, in all the edition the things have been different. Okay, so this was the lecture number 5. We'll be talking more about neurology and other topics in lecture number 6. Thank you very much.